far, far west of here and some far east of here. So it is definitely a good day, although it may be dark for some of you. We're very glad to have you. Welcome to this session, which is the World Society of Arrhythmia's Pacemaker sessions. This is number 5, and will be devoted to complications and long-term management. We're very honoured to have my co-chairman, Dr. Deepak Padmanabhan, who is Indian, and one speaker who is also Indian, although it says there on his first slide that he's maybe still in Australia. He's actually now in South India, in the city Manipal. He's distinguished by a very good academic record and lots of interest in pacemakers and avoiding their complications. So I will start by giving a little introduction to the field, and then he will take over with his presentation. So, as I've mentioned, we're going to deal with complications, and they can be divided up in quite different ways. We tend to do it early and late. And early involves things like lead displacements and hematomas, and late involves late lead problems and infections. So I know that Dr. Prabhu is going to cover all these things. What I've been looking at is, I started by looking at the guidelines of the European Society of Cardiology in 2013, when complications were single chamber about 4 or 5% and dual chamber about 8%. And we really didn't have much of complex pacing in those days. The next guidelines come in 2021, when complex pacing is definitely there. And what I noticed was that the complications were simple or relatively simple pacing had gone down. And that's rather encouraging, because I kind of didn't expect it. But we get down to maybe 2.5% for single chamber and maybe 5% for dual chamber, early and late combined. The complex pacing, which includes his bundle and left bundle branch area pacing, has inevitably a higher rate of complication. But it will go down, I'm sure of that. And it can be said to be around 8% at the moment. Are complications inevitable? I fear the answer must be yes, but I would like the answer to be no. And that is where we should strive. So this is the thinking. And one more point to make is that leadless pacing has had a tremendous impact on complications, much more than I personally expected. I looked at leadless pacing rather cynically, because at the beginning it was only single chamber. I said, what do we want to go back to single chamber pacing for? But what has impressed me greatly is that we don't have lead complications because there's no lead, and we don't have pocket complications because there's no pocket. So this is very important, and will be, I think, the way we will go. What we lack with leadless pacing at the moment is really good dual chamber. It's beginning, and I think it'll take off. And a little bit further along is the complex pacing of left bundle branch area. But I see no challenge that cannot be met. So with all of that, I have great pleasure in introducing Dr. Mukund Prabhu from Manipal to tell us about pacemaker implantations, complications, and prevention. Thank you.
Mukund, you're on.
Yep. Thank you. At the outset, I would like to thank the organizer for giving me this opportunity. Without much ado, I'll go into the topic. The scope of the presentation today will be mostly presented in a case-based fashion, and the focus is on prevention of complications. And it's not intended to be comprehensive. For example, I have not included the complex pacing technologies here. And pacemaker-related complications are discussed more rather than the pacing-related complications, which probably need an entire topic on its own. So let's start with the first case. It's a 54-year-old lady. She underwent a pacemaker around 2 days ago, develops breathlessness and orthopnea, and that's steadily worsening over minutes to hours. And along with that, she has left-sided chest pain. The ECG confirmed a normal pacing function, and this is what the X-ray shows. As you can see in this X-ray, the pacemaker leads are in situ, one in the atrium and other in the ventricle. And there's a left-sided pneumothorax. We can identify that by absence of the vascular markings in the left apical region. And the arrow points to the pleural margin itself, which shows the collapsed lung. And that's causing her pain as well as shortness of breath. She rapidly improves after an intercostal drainage was introduced. And this is probably, for the conventional pacemakers, one of the commonest complications, though the incidence itself is very rare. Among all the major complications, probably this might be the commonest one. And incidence varies based on what study you want to quote. The Danish registry is put at around 0.66, whereas the European registry places it around 1.5%. It can be asymptomatic, totally asymptomatic, and incidentally detected when an X-ray is taken during follow-up, and it can be thoroughly missed. And it doesn't have a consequence if it is small enough. But if it is significant in size, it can cause pain, shortness of breath, and when very severe, like tension pneumothorax, it can cause hemodynamic collapse as well. So risk factors: elderly patients, a dual chamber pacemaker, difficult punctures, emphysema, and the female gender. And how to prevent this, it needs much more attention. The thing with conventional venous access is it doesn't separate the venous vein as such from the pleura. They are overlapped in the AP view. And like this diagram, which is borrowed from this Europace publication of 2015, this shows that slightly tilting the fluoro around 35-degree caudal, AP caudal, elegantly separates the vein from the anterior chest wall as well as posteriorly placed lung surface. Now we know where the lung surface is, and our needle can be maneuvered in such a way that the pleura is never hit. So that can actually probably bring down the pneumothorax incidence. So AP caudal view for access, if you are habituated to it, or targeting the axillary vein rather than the subclavian vein, because subclavian vein is where the pleura is very close to the vein. Axillary vein is a bit further off, and the cephalic venous approach needs some surgical skill, but it prevents so many other complications as well, like the crush syndrome, the hemothorax, the pneumothorax, etc. But it needs a bit more surgical skill, or using the ultrasound guidance for taking the access. That also can probably reduce the pneumothorax incidence. It's diagnosed by chest X-ray, but it's not always simple because the conventional best way of taking X-ray is not possible in many pacemaker patients. We are forced to take a AP view. Ultrasound also can pick it up, and CT thorax definitely confirms it. And when it's very small, like less than 25%, conservative management would suffice with high flow oxygen inhalation. Or if it is larger, we need an intercostal drainage, especially when the patient is hypotensive or hypoxic. I think I'll pause.
Wait, before you embark on case 2, we should just have a little bit of discussion, although you presented it very clearly. The way to diagnose it is chest X-ray, of course. And the way to avoid it completely is use the cephalic vein. But all my trainees have said, I can't find it. So it does need that surgical skill, which it can be rather time-consuming and annoying. Personally, I have always used a cephalic vein, and even I've dissected out the subclavian vein and punctured it under direct vision. But that's a difficult situation. So Dr. Deepak, any comments about this?
A couple of them, in fact. One, I've asked this question before, I'll ask this question again. What do you think is the role of the micropuncture access into a vein? How does that help? Do you think it helps, especially if you're anxious and end up puncturing the lung, you'll get a smaller or perhaps no pneumothorax, it's more forgiving? That's the first one. And second, how do you prevent against getting spasms of the venous musculature, thereby increasing the chance of us going more medially for the axis? Any thoughts on both of them? Mukund or Dr. Sutton?
Mukund first.
Yeah. So in my experience, I don't find any data to compare micropuncture needle versus a standard needle. I always use the micropuncture needle when the vein goes to spasm at that point in time, or when there is an obvious emphysema and ventilated patients where the chances of lungs collapsing between the ribs I perceive it to be high. I personally believe it should reduce the chances of pneumothorax because it's a smaller bore needle. But a patient having a bulla or emphysema probably still may end up having a pneumothorax despite micropuncture needle is what I believe. I don't have any data to support this. And regarding venous spasm, I usually follow hydration starting from around 6 to 12 hours before through the same arm, left arm. I usually do it in the left side. So left arm hydration. And use of micropuncture needle is very useful when you have a spasm. And I feel it might prevent spasm as well. Hitting the artery, subclavian artery, and subsequent hematoma formation, I feel strongly triggers a spasm.
Dr. Sutton?
So for less sophisticated hospitals undertaking pacing, then I feel quite strongly in advising the cephalic vein as the way to go, because it does require surgical skill, but we can all learn that, and we don't need to pay a lot for it. Whereas chest X-ray available for everybody, ultrasound, I think probably not.
Yeah.
And so this might be something to think about if you are not having a big budget.
Absolutely.
Shall we move on to the next case?
We should. We should.
Before moving on, could I have some comments?
Yes, of course.
Well, so I have some comments about the some practical points. First of all, we mainly follow the patients during the procedure and early after the procedure by the peripheral oxygen saturation. That is a very good indication if you have low peripheral oxygen saturation for pneumothorax. And one obstacle for peripheral oxygen saturation reduction after the procedure is methemoglobinemia that may time to time be resulted from the effect of local anesthetics. So one should be careful about this. But of course, differential diagnosis is there with a chest X-ray. If you don't have a pneumothorax, then it may very easily be attributed to methemoglobinemia. And of course, the solution is much simpler than that. And the other practical issue is, of course, venography. But there are several studies showing that if you have ipsilateral venography, you may increase the risk of infection. So one should be very careful about this, but it is rescue type approach if you are failed to puncture a few times of puncture. I personally prefer puncturing the axillary vein and doing extrathoracic axillary vein puncture with this, we don't usually have pneumothorax. So this is a very critical issue. Of course, the best is always the ultrasound aid puncture, but there are several limits, as Dr. Sutton mentioned, the availability and also the learning curve. In this part of the body, the learning curve of using the handheld ultrasound is a little bit, longer. It's not always easy to just show or demonstrate the subclavian vein and axillary vein. Thank you.
Okay, thank you very much. Dr. Prabhu, please continue.
Yeah. So moving on to the next case. This is a 51-year-old man. He had this happened last year. So it was a recent antiviral MI when he developed a VT. Less than 2 weeks into myocardial infarction, he developed a monomorphic VT, and that needed DC cardioversion. So subsequently underwent implantable defibrillator implantation for a secondary prevention indication. And post-procedure, he develops tachypnea and shortness of breath the next day. And this is the X-ray, the initial X-ray, which shows entire left hemithorax is opacified, relatively homogeneously opacified, and the lead is seen in situ. And this is after we put a intercostal drainage. This faintly seen here, I put an arrow here, the drain entering the thorax. It's not very clear because of the higher, lesser contrast. And that drains around 300 ml of blood, almost non-diluted blood. And with that, his symptoms improved. And over a period of time, 3 or 4 days, we could remove the drain completely. This X-ray normalized. So this is the next not so common sort of complication. Incidence is reported to less than 1%, and it can be access-related, vascular or direct lung injury with the needle, or more fearful is when it's related to the lead. The lead can perforate into the pleural space. It can cause hemothorax even without a pericardial tamponade or pericardial effusion. And rarely we can have an opposite side. I myself had a case, as well as I read about reports. When you have an atrial lead, you can have a right-sided hemothorax when it perforates into the right-sided pleura. So any combination is possible. Usually it's a left-sided in left-sided procedures, but rarely you may have a contralateral hemothorax as well. And access-related ones generally needs just a drainage. They will settle, whereas other ones due to lead perforations needs a different sort of approach. I'll pause again for discussion here.
Thank you. I mean, this is all a bit similar to the previous case. This one is worse, but the way of dealing with it is similar. And I just wonder, was this patient on some sort of anticoagulant or?
Yeah, he was on dual antiplatelets, especially ticagrelor, because of his recent stenting.
So this makes the problem a little bit more likely, of course.
Yeah.
How long did you discontinue that before the procedure?
I generally never discontinue medications, especially when a patient is stented. If there is no recent stenting, I do stop around 5 days before, if there is a ticagrelor, 2 to 3 days back. But aspirin alone, I never stop. And now I've done maybe around 10 to 15 cases while on ticagrelor. This is only a case where I had a complication.
Dr. Deepak, any comment?
It brings us to the very challenging concept, especially for patients on valves, for patients who have atrial fibrillation, and patients who have stenting. What should be the ideal way for the pre-op anticoagulation or antiplatelet agents to be managed? There is no perfect answer, but I would love for everybody on the panel to kind of educate us about it.
I think we probably need Ali for this.
Yep.
Ali, you still there?
Well, I'm there. Yes, just following you. Well, it's true that this is a really challenging issue. Again, if we go back to the puncturing, so the main issue is a safe puncturing. And one of the major reasons or causes of hemothorax is arterial puncture, particularly in cases that you mentioned, I mean, or those who are on oral anticoagulation and oral antiplatelet agents, etc. So if you have arterial puncture, I mean, incidental arterial puncture, please be more careful in doing more punctures and then try to prevent further damage to the subclavian artery or arterial structures. So this is one thing. The other issue is, well, as everybody does, we are not so much conservative about the procedures in those who are on oral anticoagulants. So we do not really do bridging. And I'm not so much concerned about doing procedures in those who are on dual antiplatelet agents. But of course, in those cases, again, you must be more careful about the hemostasis after the procedure. And sometimes, well, I observe the patient's wound, and if needed, I always use drainage, very short term, 24 hours or so. And I sometimes change my strategy in, I mean, closing the wound. Sometimes not sub-Q, but regular, I mean, wound closure, etc.
Thank you. Something I found very helpful is handheld diathermy.
Yes.
So you can use that. You don't need the big machine of the surgeons, and it's very effective. And you throw it away at the end of the procedure, which is an expense, of course, but it gives good hemostasis in almost every case. And
Absolutely.
for such a patient as this one discussed, the cephalic vein might have been very good, even though the leads are quite big, of course. I claim a world record for leads in the cephalic vein, 32 French.
Wow.
Beat it if you can. So shall we go on to the next case?
We should.
So the next case is a 64-year-old man with ischemic cardiomyopathy. He has underwent multiple percutaneous coronary revascularization procedures, and he has severe LV dysfunction and recurrent heart failure episodes needing hospitalizations, as well as recurrent VTs. And he underwent a ICD implantation. So when I took the first puncture, he had cough. I could manage to get access to the second puncture, and I completed the procedure subsequently very smoothly. And after switching him over to the ICU, he immediately developed a hemoptysis, almost within 20 or 30 minutes after the procedure was complete. And this is a frank blood that is spat out, and he was not having any shortness of breath. Initially, I was concerned, I was worried. I thought it might be a lung injury. And this is the X-ray immediately done after the procedure, which shows some inhomogeneous sort of opacification in the left upper zone, which was not there before the procedure. Had a massive cardiomegaly, but essentially those lung fields are clear. There's a defibrillable patch which was put before the ICD was put, and this turned out to be an alveolar hemorrhage. It was self-limiting. It subsided in a day. The very next day, he has clear mucoid sort of sputum, and it never recurred. So I didn't pursue this with a CT scan. And I read about this complication. It's reported to be quite rare, around 0.1 to 0.3% of pacemaker implants. It happens when your lung is directly injured by the access needle, puncture needle. And sometimes it still happens when we don't cross the medial border of the first rib, because the lungs itself can collapse between the ribs, especially in the elderly.
So I think it was good to hear about this, because this is a rare complication which should always be borne in mind. But I think we will not discuss this. We'll move to the next case.
So next case is actually, it's not my case. I borrowed this from my friend Dr. Vijayan Ganeshan. So it's pulmonary air embolism. we are not very careful during the procedure, this can happen. It's quite common. Small amounts of air getting aspirated. So what happens here is air gets sucked into the venous system through the sheath. And more often with deep inspiratory efforts when patient is having dyspnea and all, and when the venous pressures are low, like in dehydrated patients. And we can prevent this by pinching the sheath to seal its lumen till the lead is advanced. And valve sheath also help in preventing it. So this is the image showing the RV outflow tract and the pulmonary wall being highlighted by the air, this translucent thing here. And after the ventricular lead, before the air lead was placed, you can see that there's quite a lot of amount of air in the right ventricular outflow tract. And this is the way it needs to be prevented. If your sheath is not valved, we have to pinch it till the lead is apposed into the sheath. We published this case subsequently. And air silhouette is how we diagnose it, easily picked by the fluoro. And very rarely you may have hypoxia or hypotension. Usually it's self-limiting, and high flow oxygen inhalation suffices. Rarely inotropes, and very rarely aspiration of the air using a separate catheter like through the femoral vein can help. We'll pause here for a discussion.
Dr. Deepak?
This is a nightmare, especially when you're having fellows support you on cases and you're helping them do it. This remains one of the biggest challenges that I have faced. How to prevent them from getting the air into the circulation. I found it easier to take the sheath out once the leads are into the circulation, especially for the atrial ones where the sheath remains a little bit larger than the lead itself. But there hasn't been a very good way for me to be able to transfer care and simultaneously do it with two people to prevent this from happening. Small amount of air, I find larger the sheath, the air getting in remains a problem. And other than using a valved sheath, I've never been able to manage this on a consistent basis. We've never had something like hypoxia or hypotension, but it always makes me skip a beat when I see even a little bit of air in the outflow tract, especially in patients who are elderly and in patients who have compromised pulmonary function. That remains a big challenge. I always end up looking for the backflow of blood through the sheath, and that remains a step that allows me to diagnose or at least anticipate this challenge. Very rarely, if the patient is well cooperative, I've asked them to hold their breath while I'm putting the lead in, at least introducing the lead in. And getting the lead into the circulation is usually a very, it's a thing of anxiety for me because I want to get it in at least up to the SVC before I peel the sheath off. I do it very early in my procedures. What about you, Dr. Sutton? Dr. Otto, any thoughts on the same?
I think that having a well sedated patient helps, because if they're wide awake and nervous, they're more likely to take deep inspirations, which would be very embarrassing and provocative of this. Let me ask you, Dr. Deepak, you prefer not to use a valve sheath. I think I understood. Is that because you find manipulation difficult, or the slitting business difficult, or?
No, the availability and the cost. It eventually drives up the costs. And for a simple pacemaker, for sure not. Even for an ICD. For the CRTs, you all automatically get a valve sheath, so that's not a problem. It's also something that you can say in favor of the conduction system pacing, that at all times you will get a valve sheath.
Yes.
So one other reason, if not for mechanistic reasons, to shift to conduction system.
Ali, any comments?
Well, indeed, actually, in earlier times when we used to use the sheets without valves, it was still a very, very rare complication. It happened to me once when I was helping a fellow to implant a pacemaker. It was a massive pulmonary air embolism, but we were very lucky and we were successful to really drain the air with with a separate catheter and prevented really the air mass going into the pulmonary system and to the circulation.
Thank you.
Thank you.
Dr. Prabhu, please be kind enough to continue.
Yeah. The next complication, I don't have a case. I'll just summarize it. It's a deep vein thrombosis. Luckily, it's very rare after a pacemaker implantation. Usually, it manifests within days or within the first month itself with pain and swelling of the ipsilateral arm. Sometimes you may see the venous collaterals open up on the chest wall. And risk factors, more the number of leads, more likely this is to happen. And difficult access where the needle has caused much trauma to the venous wall. And Doppler imaging easily diagnoses it, and treatment options include warfarin as well as select cases intravenous thrombolysis, preferably done by an interventional radiologist. I don't have a case to show here. After this, I would like to go to lead-related complications. I have completed the access complications now.
Okay, I've seen this maybe twice in 5,000 cases, so I think it's fairly rare.
Yeah.
And but much more common chronically.
Yes.
You mentioned the dilatation of the veins over the chest wall around the pacemaker site, the pocket. That is more common. We probably can't avoid that, though. Leadless pacing is the future.
You stole the words out of my mouth.
Please go ahead with the next case.
Yeah. So next case is a 51-year-old man. He presented with fatigue. On evaluation, he was found to have a hypertrophic cardiomyopathy for the first time at the age of 51, as well as complete heart block. So, given the substrate of hypertrophic cardiomyopathy, he opted for a defibrillator rather than a pacemaker, and he underwent a dual chamber ICD implantation. 10 days post-procedure, he presents in the night with episodic severe chest pain. At presentation, he didn't have any pain, but it always comes as severe episodes. It's almost excruciating and disabling. We did a rapid echo, which showed no effusion, and we did a chest X-ray, which was normal as well. And coronary angiogram was screened which showed normal patent coronary arteries. And then we took him for a CT scan. The CT scan was interesting. That obviously the lead-related artifacts are there, but still it could make out that the lead is perforating the RV, right ventricle, and coming out. And this cut clearly shows a large hemothorax. With this, the diagnosis of surprisingly, the lead threshold was only marginally high, like 1.5 or so, and sensed R wave as well as impedance were normal, and that was the initial confusion. Before we went for the CT, and subsequently we repositioned it, and we could manage without any pericardial aspiration and all. And 2 years down the lane, he developed ventricular fibrillation, probably because of his hypertrophic cardiomyopathy, and got an appropriate shock. So we were happy that we chose for an ICD rather than a pacemaker at that point in time. Regarding lead perforation, it can be acute within 24 hours, subacute up to 1 month, or even chronic after 1 month of implants. It's more common with active fixation than passive fixation leads, and RV as well as RA leads can perforate. Rarely, the coronary sinus lead also can be involved in perforation. Can manifest as pain, pericardial effusion, or even tamponade. And it's very important to recognize that perforation can occur without effusion. And pleural effusion or hemothorax too is possible if the lead perforates into the pleura or injures the lung. Changes in lead impedance are confusing. It may not always be there, but more often threshold and sensed wave do differ if you compare with the original parameters. Can present as pacing malfunction or a failure, change in lead parameters. Diaphragmatic pacing is another common presentation. Sometimes you may have pericardial effusion. Imaging with CT or MRI is always preferred compared to X-ray or echo alone because it gives a better anatomical delineation.
Question. Sorry, you haven't quite finished. Finish off.
Okay. So things to prevent perforation should happen at the time of implant itself. As we know, it's more common with active fixation. So in some sites, if we are not comfortable, we can choose passive fixation ones. Certain areas of the heart are more vulnerable for perforation. The right atrial appendage, the right ventricular septum towards its anterior aspect where it is insert into the septum. The right ventricle inserts into the septum, the so-called anterior groove. Then the RV proper apex is commonest site of perforation. Lead manipulation should be extremely careful, especially when we deal with the stillet. This is a picture of a right atrial appendage. The thickness is not uniform within the appendage. There are places where that it has thick muscle bundles, and there is interspersed very thin areas, maybe barely 2 millimeters. So it's actually very easy to perforate the right atrial appendage. In fact, many surgeons actually see screw protruding when they take pacemaker patients for different surgeries like CABG. So it's not uncommon at all for the lead to go into the pericardium, though clinical effusion is rare. When it comes to the ventricle, this is the RA view. We can actually imagine a grid, anterior regions, mid regions, and the posterior regions. You should always aim to leave the lead in the mid portion, mid septal. Even if it perforates, tamponade and effusion will be rare. Perforation itself will be less common there, rather than going to the anterior most or the posterior most or apical most areas where the chances of perforation are more. So key to successful implantation is understanding the anatomy and imagining it in fluoroscopy. Like especially in the RIV, for example, you should know where the appendage tip is, where the AV groove is, where the apex is, and anterior, mid versus posterior sort of septal lead locations. I'll pause here for discussion.
Forgive me, but your diagram that you showed 1 or 2 slides back, it gives a false impression of the right ventricular wall, which can be 1 or 2 millimeters thick. And it looks quite thick on your diagram.
Okay, fine. Yeah. This RA appendage, yeah.
We've always got to be careful of that. I think use of the Bisping type of active fixation lead, where you don't advance the screw until you're in position, will help to avoid some of these complications. Another thing which is valuable is to examine the unipolar electrogram from the lead tip. And I suggest that that's done before the lead is screwed in, where you'll see quite massive ST elevation in the unpaced complex. And if it's too far in, you will not see that. And so screwing in with an ST segment that's isoelectric, you will almost certainly get outside when you've finished screwing. So that's maybe a good way to avoid it. Post-operatively, maybe always auscultate the chest and listen for a pericardial rub. They're really rather common after pacing. So we do things that we don't think we've done. And if you've got a massive effusion, you won't hear a rub, of course, but small effusions you will. Dr. Deepak, other thoughts?
It's the nightmare. Honestly speaking, this is the one complication I make it a point to discuss with every one of my patients, because despite the best of our skills, I find it is not possible to guard completely against it. Even if we end up preventing complications because of ventricular challenges, either perforation in the RV, anterior wall, and so on, it's still quite naive if we think we're going to be able to ever make atrial perforations zero. I just find the atrial lead to be a very, very anxiety-provoking lead whenever I'm putting it in. As you said, I never deploy before ensuring that the unipolar has a proper ST elevation, is not changing, and never always to the lateral wall. But even with that, it would be very hard for me to say I've never perforated. I don't know if it's always led to an effusion or if it's always led to something that needs to be done for the patient. Thankfully, I've not had that challenge so far, but I'm pretty sure some partial perforations may have been there. And as you mentioned, the rub, as well as either a sudden onset pain, unusual pain that increases with deep respiration, either in the immediate aftermath of the case or even on follow-up. I find it's not uncommon to find pericardial effusions after 6 months of follow-up. you've been perfectly normal, and all of a sudden now you started developing a pericardial effusion. So I just think it's a progressive thing. We are lucky that we have those retractable leads where the screw gets pushed out instead of us trying to screw them in. And it presents with a diagnostic and therapeutic challenge as to what is to be done eventually. Do you reposition? Don't you reposition? Do you keep the surgeon on when you're thinking of repositioning? And so on and so forth. It's just one of those things that I don't think is ever going to go away out of pacing.
Well, one further way of avoiding the right atrial perforation is not to put the lead in the appendage.
Yep.
It's too thin, and leads ought to go at Bachman's bundle.
Yeah.
But that's a future story. Shall we go back to your cases, please, Dr. Prabhu?
Could-
This is the video to show how the lead behaves when the stiletto is pushed all the way up to the tip versus not. Above panel is more loose or flexible, whereas it's more rigid in the below panel where the stiletto is pushed all the way to the tip. It behaves more like a weapon rather than a force.
This is very nice.
So next case is a 57-year-old man with complete
some
heart block.
comments before moving to the next case?
Yep.
Well, first of all, I really echo what Richard have said about the prevention. I think, of course, the besides the location, of course, the manipulation and the screwing behavior of the lead are always critical. And for the diagnosis, of course, ECG is a very important tool. And as you move from the endocardium to epicardium, then you will see the electrical changes from, of course, the left bundle to right bundle branch block pattern. And this should really bring the possibility of perforation always to mind. And beside this, for the diagnosis, I would really strongly support the role of a careful echo examination. So you can identify the tip of the electrode perforated and reach out the ventricle into the pericardial space, sometimes with effusion or even without effusion. And of course, one other thing that I forgot is the pacing threshold. Of course, you may not really detect any change in the impedance, but the threshold many times is increased after the perforation, because it's not so easy to pace the ventricle from outside. So in chronic phase, I haven't really had myself, perforated, but I had several referrers in chronic phase, and always, one should be very careful while taking out the lead. Of course, there is always the risk of acute tamponade, but never happened to me. Thanks God. I don't know, but this doesn't mean that doesn't or will not happen. So be careful about the possibility of tamponade, but in chronic cases, it's always low, probably because of the defense around the electrode, fibrotic defense around the electrode. Thank you.
Thank you. Dr. Prabhu, please.
So the next case is a 57-year-old man with a complete heart block, underwent a temporary pacemaker for the very next day with a permanent pacemaker. And after the permanent pacemaker, one more day later, he complains of chest discomfort, palpitations, and neck pulsations were observed. And this was the ECG, which showed AV dissociation. Ventricle pacing was happening, but there was AV dissociation. And this was the X-ray, which carefully seen shows that atrial lead probably has fallen, and we did the fluoro, which confirmed that atrial lead is lying probably in the tricuspid annular region. and subsequently we took him for repositioning and could restore the atrial appendage location. So lead dislodgement is any evidence of electrical or imaging suggested displacement of the lead from the original implant site. It's a common complication of pacemaker procedures, around 1% in ventricular leads and around 4% in atrial leads. Typically an early complication, but can happen after a few weeks as well. Undersensing, loss of capture, change in phase wave morphology like QRS becoming LBB to RBB, or even the P wave morphology, if you compare with the original morphology, all of that gives us a clue. And some risk factors can predict this. One is obesity, female gender. Passive fixation leads tend to get displaced more often than active fixation leads. And prevention is to ensure a good current of injury and slew rate so that you are sure that you are in contact with the myocardium. Ensure fluoroscopic stability. Be very careful during lead manipulation and gently push under fluoro to see whether it's caught the myocardium. The tip should not move further. The deep inspiration and coughing, especially when you pace at the threshold output to see that there is loss of capture with movement of the heart or thorax. Then adequate slack needs to be ensured, and good anchoring of the lead and the pulse generator to the muscular layer. All of them are believed to be reduce the incidence of this lead displacement. We'll pause here for discussion.
There's one additional risk factor which I would like to add, and that is the taking of a chest X-ray, because not all radiographers are like this, but some of them want the patient to raise the arms suddenly and highly, and that can be enough to displace the lead.
Absolutely.
Yeah.
So Deepak, please.
Mukund, can you tell us how you anchor the lead? I mean, that's been a topic of some discussion.
Yeah,
And
I think there are multiple ways of anchoring the lead, and each school of thought has their own arguments. What I follow is I first tie the suture over the sleeve so that lead is caught well within the sleeve, and then that entire thing I anchor to the pectoral muscle or the fascia. If the muscle is not acceptable, like in pulsation change with lead revision and all, I sometimes use the fascia, but I prefer muscle. I don't go take it in a single go, where entire
Agreed.
muscle as well as sleeve is sutured together.
nice.
What about you, Deepak?
Sutton? Yeah.
Do you agree with that?
I do both of I do one of each. So I end up taking a bite out of the muscle and then suturing it to the lead.
Yeah.
One of my staff members is always holding the lead sleeve across the lead in position while I'm doing that. For the other two, I kind of take it directly. I at least want one good solid suture without it directly being onto the muscle. What are your thoughts, sir?
Yeah, I like the way that Dr. Prabhu described, but I would emphasize that what goes round the lead must be with the sheath.
Yes.
There's a groove in the sheath,
Yeah.
which it was where we should put the suture. That's where I've always put it. And if you don't do it, then displacement is really quite likely. Shall we go to the next?
Yeah, I just want to ask one question, just because you told that X-ray thing. Do you suggest arm movement restriction after pacemaker? If so, how long do you suggest arm movement to be restricted? Specifically lifting the arm or taking it behind the body?
Yeah, this is a good question. And the balance is between not displacing the lead and getting frozen shoulder.
Yeah.
And so the first 2 days, I say to the patient, don't lift your arm up. And then gradually restore that movement over the next 5 days. So normal movement at 7 days.
Nice.
Shall
We do end up, sorry, go ahead. We do end up giving some arm rests for the patient, slings for the couple of days so that they kind of remember that they have a device in place and they are restricting their arm movements. That's something that we do.
Good. Case 6.
Yeah, case 6 is a 64-year-old man, had underwent a dual chamber pacemaker back in 2009 for complete heart block and presented with syncope. And this is the ECG presentation, which clearly shows some of the P waves are not tracked. Obviously, there's probably some oversensing, and interrogated the device. which showed that there is some electrogram noise seen in the ventricular channel, and that's why the PO is not getting tracked. And this is a chest X-ray, fluoroscopic shot, which shows probable lead insulation failure here at this point. And lead impedance was also quite low. And this was lead insulation failure due to subclavian crush syndrome. It's typically a chronic complication of pacemakers with leads. And lead is constantly compressed at the thoracic inlet between the clavicle and the first rib. And over a period of time, the insulation as well as the conductor can get damaged. And it's less often seen with subclavian venous access or even axillary vein access. So risk factors are older patients, older and thicker leads, multiple leads, patients with low BMI. And prevention might be with cephalic or an axillary vein sort of target. I'll pause here for discussion.
We should reflect on that very nice diagram you showed from Europace on how to do the subclavian puncture. Because where you said it should go in, you should never, if you do that, you should never get crush.
Right. I also think you feel the ligament. I mean, I don't know if any of you do that, but if you go closer, you're actually able to feel your way through either going through a muscle or going through a ligament while you're touching to get to the vein. That itself is, for me, a challenging point to suggest that, look, there is some resistance there, which over a period of time might cause crush. Getting out to the lateral half of the rib or going to the axillary vein for access seems to be a much more safer thing to do, especially because if you were to extract this lead for whatever reason, it's an absolute nightmare to extract a crushed lead.
Good. Have you another case?
Yeah, thanks.
Yes, sir.
This is the last part of my presentation, and this focuses on wound-related complications. There are so many to be, if you want to mention, like delayed healing, stitch granuloma, hematoma, ecchymosis, infection of the wound, as well as the pocket infection. I'm not going into individual cases, but I'm just showing the examples. The first one, where actually it was healing well, apart from the fact that some spots it was not, and it was like skin has been lost there. And probably this was related to electrocautery burns. When we inadvertently touch the cautery on the skin, we may result in such burns, and that portions can get delay for healing. Yet another cause is the suture material protruding out from the, usually it happens towards the apex of the wound where we knot it. And if you have not buried the knot properly and it is jutting out of the wound, that particular portion can fail to heal. And in this particular case, there was a small thread coming out, which was pulled out and cut off, and subsequently the wound healed. And this is another non-healing. These two diagrams from the same patient actually. He had a sepsis as well as chronic liver disease, and I was forced to do a pacemaker because of the complete heart block. And because of low albumin, probably the wound just didn't heal initially, and I had to take it for secondary suturing, after which it healed. And this is a case of ecchymosis. There was no pocket hematoma, but entire shoulder region was having this bruise sort of thing. Usually it's self-limiting, though it causes discomfort and pain initially. And frank hematoma can cause a bulge as well as a fluctuant swelling, and it's not common and can be prevented by using a electrocautery for good hemostasis. Yet another wound-related complication is wound dehiscence. This particular lady underwent a CRT. 2 weeks afterwards, I wanted to remove the sutures, and I called her. The moment I removed the suture, I could see the pulse generator. It was not as gaping as this, but nonetheless, I could see it. I took her to the theater, and then secondary suturing was done, after which it was healed. This is another case, 3 months post pulse generator change, a long QT syndrome lady. Did a pulse generator change for an ICD, and around 3 months later, she came with this. And 2 or 3 days later, I just could see the device when I cleaned, or it gave away on its own. It was sterile. There was no pus. It was just a clear fluid, and the device was visible. Then now we call it erosion. It's another case of erosion, and this one I labeled as necrosis. Is actually delayed healing with blackish discoloration. Usually these wounds will be dry. They'll not be having any discharge and all. And it happens because of skin tension. And with bigger devices like ICD and CRT, thinner patients with no much fat, if you are not using subpectoral pocket, the skin itself stretches over the device, and that can ultimately lead to delayed healing. And these black patches are necrosis. Sometimes you need to excise the entire thing and take for secondary suturing. And this is a very rare thing. I've only seen this once in my practice. Something coming out like protruding like a needle. It was very sharp here, and it was not causing any damage from my perspective, but the patient found it very irritating. And after a few months of waiting over it, then finally again re-explored and sent for biopsy just to realize that it was the black silk with surrounding granuloma tissue formation that was jetting on the skin from the inside. So there are so many other sorts of complications also which we frequently encounter. The decision is when to intervene and how to prevent. So the prevention should start with aseptic precautions for prevention of infections. Alcohol-based disinfectants are better than just plain betadine. And one dose of prion antibiotic has a proven role given around 1 hour prior. We all of us here in India, we give post-op antibiotics as well. They don't have any data backup to prevent infection. And many of us follow local infiltration of antibiotics. Again, dubious role, but we do still do it. And adequate hemostasis cannot be overemphasized. We have to use the cautery if needed. And even small hematoma can invite infection because hematoma draws, because of hyperosmolar state, it draws more fluid into it and it becomes an anaerobic milieu. And if it gets infected, it's a real pain. Proper skin closure is very important. No suture material should jut out of the wound, and the skin should not be under tension when you finally close it. Pocket size need to be adequate, otherwise the skin can be under tension, and suture material we already discussed. Delayed healing may need surgical consultation occasionally, especially when the skin is necrotic, and superficial infections can be conservatively managed. Any erosion when the device is visible or the pocket is involved needs the entire system to come out, explantation or extraction. If there is a pocket hematoma, try never to aspirate it with a needle. Usually we can manage it conservatively. If not, probably better is to take to the theater and explore it and evacuate it in an aseptic manner. I think that's last of it. I will pause here for discussion.
You seem to make a contradiction there. I'm not sure you intended that. You say never aspirate with a needle.
That's how like we are taught as well as we follow, because we'll end up introducing infection if we are aspirating with the needle. Other than probably we can take it to the theater in a better aseptic manner. We can open and do it. Even suction, use suction also to aspirate the hematoma.
Yeah, it's a serious business. It has to be done in an aseptic manner. I agree.
What has been your experience using antibiotic impregnated pouches?
Yeah, good.
For pack changes? There seem to be a couple that are coming up these days.
Is it to me, the question?
To the panel. If you've used them, would love to hear your experience too.
Yeah, I did use them, but I don't prefer them always. What I look at it this way, in literature as well as in my practice, incidence of pacemaker infection is less than 1%. So if you start using pouch for all patients, I don't know what will the NNT or the number needed to treat will be. It will be exceeding 500 or 1,000 for sure. And most of my patients won't afford that. I do use it when we have a pulse center change, a CKD patient, already infected patient, or infection somewhere like cellulitis in the leg, etc. I do use it, but it's not a common thing in my practice.
Very nice.
I would think, I mean, I've never used these pouches, but patients who had an infection and have to have a redo, that might be a good indication for using one of those pouches.
Mm-hmm. Dr. Ali, is he around? His use of these pouches also might be very valuable.
Well, actually, I have not used the new generation of the pouches, but in the past I tried a few. At that time, particularly in the pediatric cases. Well, to me, it's not always needed, but the careful pocket management and very careful closure of the wound is important. Probably the closure of the wound is the most critical phase of the pacemaker implantation, I would say, for the long-term follow-up.
Absolutely.
It is the easiest part, but the most, critical part, the gatekeeper for the infection.
Always two lanes.
Yes.
Always close in two lanes.
Quick question before we move on. Monofilament suture or multifilament suture? It seems to be a topic of discussion always.
Well, I used to use the multifilament sutures, but over the last, I would say 10 years, I've been using monofilament ones. So I have not had any problem with.
Same here. I
Mukund.
always use monofilament. I have never used multifilament. I think I have given a thought to this actually. The discussion mostly is theoretical. Whatever complication we see because of multifilament, it's extremely rare. If you are thinking about infection, it's extremely rare if you are following the adequate precautions. I don't know how much difference it will make. But having said that, I have never used multifilament. I've used only monofilament.
Has anybody ever used staplers to close?
Yes.
I come across some of them sometimes.
Yeah, I've used.
For the skin layer. Yeah.
I prefer one stitch for the whole wound.
Yes.
So
Very
we've kind of finished the program. I think that we're probably out of time. We haven't had any questions from the audience. And do we have questions from the audience?
I don't see them on the chat, so I would imagine on follow-up we might get some.
So in that respect, I would be happy to answer any questions that come to the Magnum office and do it by email.
Sounds like a plan, sir. So we'll have Dr. Prabhu give us his take-home messages and then one final word to sum it all from you, Dr. Sutton and Dr. Otto.
Thank you. Go ahead, Dr. Prabhu.
Yeah, I think it's just a summary of pacemaker implantation is associated with small risk of complications, and some of them are at least preventable. Meticulous precautions right from the stage of planning and during the procedure is the key to prevent them. And access is an important step and needs stringent attention to prevent most of the dangerous complications like hemothorax or pneumothorax. I think that's it from my side. Thanks for kind attention.
Well, I think we must thank you, Dr. Prabhu, for an excellent presentation in a very practical way. And as you've noticed, it caused quite a lot of discussion amongst the others here on this panel. And I sincerely hope that this discussion has been valuable for less experienced operators. I believe that it will be. So I thank you, I thank Dr. Deepak, and for Aliato for his very important interventions. So we'll close here, but do remember, if you're in the audience, you want to ask something, send it by email, and I will undertake to answer it for you.
Thank you. Thank you so
Thank you,
much.
everybody. Thank you to the audience.
Thank you.
Thank you for the support we've had for this program from Medtronic.
Thank you so much. Thank you, everyone.
Thank you. Thank you for the opportunity. Thank you, Deepak. Thank you, Richard, sir, as well as Otto, sir. Bye.
Bye. Bye.
Bye.